Our first speaker is Pam Kunz, who's the Associate Professor in Medical Oncology here, Director of the Center for GI Cancers, the Chief of GI Medical Oncology, and the Vice Chief of Diversity, Equity, and Inclusion for Medical Oncology. She received her medical degree from Dartmouth and residency and fellowship training at Stanford, where she joined the faculty. And she joined us now in 2020. She's an international leader in the clinical care of patients with neuroendocrine tumors, conducting important clinical trials in this area, and as well as translational science for patients with this rare diagnosis. She's also a vocal advocate for women and underrepresented groups in medicine. And recently, the Women's Leader in Oncology named her the 2021 Women Oncologist of the Year. So we're very happy to hear, and we'll hear about GI neuroendocrine tumors, I suspect, from Pam. Thank you.
Thanks, Dan. See if I can switch here. There, how's that? Looks perfect. Okay. All right, excellent. So thanks so much for the opportunity to speak today. I will, in fact, be talking about neuroendocrine tumors and establishing the Yale Neuroendocrine Tumor Program. I'd like to highlight this is broadly part of the Center for GI Cancers. We have a new Twitter handle and email, which is here. These are my disclosures. I'm going to go over just a brief outline of epidemiology, nomenclature, and some key characteristics of NETs that impact treatment. We'll talk some about treatments, some clinical trials in which I've been involved over the last few years, and why we should create a NET program at Yale. And then we'll finish with some future clinical and research opportunities. I like starting with a little bit of history, and I think this one is especially important. So neuroendocrine tumors were recognized in the late 1800s and early 1900s. The term carcinoid, which means cancer-like, has been attributed to Dr. Oberndorfer, a German pathologist. He felt that these had 5 key characteristics: that they were small and multifocal, had undifferentiated cellular formations, well-defined borders, no metastatic potential, and were slow-growing and harmless. Though this was a very important contribution to the field, we now know that these tumors can in fact metastasize. They are in fact cancers. And unfortunately, this really held back the field. In fact, for many, many years, these were not incorporated or included in cancer registries, and therefore it made epidemiologic and other studies very difficult. So we fast forward to the 1980s when we developed streptozocin and octreotide for the treatment of neuroendocrine tumors and hormone hypersecretion. And then there was really a desert of therapeutic and diagnostic advances for almost 30 years. And then you can see an explosion of research starting in 2011 with a number of FDA approvals for everolimus and sunitinib and pancreatic NETs and so on. I'm going to go into a little bit more detail on this. Up on the top, we see that there are actually 3 new novel imaging modalities, 3 types of PET scans with different radioisotopes. Those have really completely replaced the use of Octrea scans. So it's been an exciting time to be in the field. I'd like to also really dispel the myth that NETs are really that rare. So they are in fact low, have a low incidence rate. So that's the number of patients diagnosed per year. And we can see that in this figure from a SEER epidemiologic study. In yellow is the incidence of NETs. The corresponding y-axis is on the left. So at present, we have about 7 to 8 diagnoses per 100,000 patients in the United States. However, in the figure on the right, I like to also describe that these are a higher prevalent cancer than was previously recognized. The prevalence meaning the number of patients alive at any given time. And the net prevalence actually exceeds that of stomach and pancreatic adenocarcinoma combined. So I think it's a bigger public health problem. Many primary care, general oncologists will see these patients. NETs are epithelial neoplasms that are derived from neuroendocrine cells throughout the body. As Dan said, I'm officially a card-carrying GI oncologist, but they do in fact happen throughout the body. GI tract most commonly, followed by lungs and then other. And I actually see NETs of almost every primary site. I just saw a base of skull NET last week. So most grow slowly in comparison with their adenocarcinoma counterparts. The majority are sporadic, with only the minority associated with inherited familial syndromes, such as MEN1, MEN2, von Hippel-Lindau, and neurofibromatosis. Pathognomonic for this disease are the presence of somatostatin receptors on the surface of the cells. There are 5 types, and over 80% of NETs overexpress somatostatin receptor type 2, and we can take great advantage of this in terms of diagnostics and therapeutics, and we'll talk about that also. Just a brief mention, this is a really cursory overview of NET biology, but I did want to bring this in. Large-scale chromosomal alterations are common. Tumor mutation burden is low in the NET, so that's the lower grade 1, 2 neuroendocrine tumors. It's higher in neuroendocrine carcinomas, that's the grade 3 or poorly differentiated. Recurrent somatic mutations are actually rare. There have been a number of fairly recent studies. So in pancreatic NET, we will see somatic mutations in MEN, DAX, and HRX. We see mTOR pathway gene mutations, MUT-YH, CHEK2, and BRCA2. And there are proposed or hypothesized at least 4 different molecular subtypes of pancreatic NETs. And in small bowels, we will see mutations in CDKN1B. Tumor grade progression does occur in pancreatic NETs, and we have seen clonal evolution patterns as well. There was a very elegant study done by friends and colleagues, doctors Nitya Raj and Diane Reedy-Lagunas at Memorial, that demonstrated this. And then germline alterations are also more common than previously thought. So in the Scarpa Nature paper from 2017, 17% of, quote, sporadic pancreatic NETs actually had germline mutations. In terms of a diagnostic workup, the mainstay of imaging is cross-sectional. So either a multiphasic CT, and that is key when you order a NET CT, so you have to order it as multiphasic, specifically with an arterial phase, and or MRI. Somatostatin receptor imaging complements the cross-sectional imaging. Octreoscan has been completely replaced by the gallium-68 dotatate or copper-64 dotatate PETs. We still occasionally will use FDG PET, but that's really only for high-grade, poorly differentiated disease. And as you can see in the figure on the left, this is a cross-section through the liver with 2 hypervascular liver lesions shown in the arterial phase of the CT scan. So that's really important, as these can be missed if that arterial phase is not done. We also, tissue diagnosis is important. We try to find the primary site, as there are some differences in FDA approvals by primary site. And then key minimum data elements on pathology include WHO grade, Ki-67 mitotic index, and degree of differentiation. Tumor markers are not all that helpful for NETs. In fact, chromogranin A, which has historically been used pretty widely, is in fact falling out of favor. I don't use it anymore. 24-hour urine 5-HIAA, which is a metabolite of serotonin, is useful for those patients in whom it's elevated. And then there are also other specific peptides and amines, which we'll speak about. So I like to think of 6 key patient characteristics that impact treatment. We'll go over these briefly: hormone status, stage and burden of disease, grade and differentiation, pace of growth, primary site, and somatostatin receptor status. These all yield potential clinical and research questions. So I think it also helps frame the rest of the conversation today. So in terms of hormone status, we divide patients into functional and non-functional. Functional refers to patients having symptoms from a measurable hormone. Carcinoid syndrome is the classic example. So this happens in about 10% of small intestine NETs, and this is due to production of serotonin. Patients may have flushing and venous telangiectasia, as shown in the picture on the left. Patients are often misdiagnosed as having rosacea. They can have diarrhea, bronchospasm, valvular fibrosis, as seen in that second picture, which is fibrosis of the pulmonary and tricuspid valves. Pancreatic nets can also secrete hormones in about 40% of the time, most commonly insulin, followed by gastrin, glucagon, and vasointestinal polypeptide, and the symptoms are defined by the hormones secreted. And then non-functional nets are patients who are asymptomatic or have symptoms that are not from hormone excess. Stage and burden of disease, it's important to think about, do they have localized or metastatic disease, liver dominant, or widely metastatic, or low volume or high volume? And our new DOTA PETs really are the best tool to help us determine extent of disease. So as you can see on the left, this is a localized pancreatic net with, you can see the pancreatic net here in the middle. Liver dominant disease with a liver really filled with tumor metastatic disease, and then widely metastatic disease. And these are actually bone lesions throughout the axial skeleton. AJCC staging follows other solid tumors, but the key point I want to make from this slide is that nets were actually only added to the AJC staging as of 2010, so relatively new. Grade and differentiation is important. I just have highlighted the two most recent WHO classification for thoracic and digestive nets. They are, I'd say, loosely related, but there are some nuances. And suffice it to say that the nomenclature and evolution of the WHO classification and what we call these tumors is complicated and has changed a lot over time. I'd like to just bring you to this right column of the 2019 digestive WHO classification. So we now have well-differentiated grade 1, 2, and 3 nets, and then a poorly differentiated neuroendocrine carcinoma. So that word carcinoma implies that it is grade 3 and has a Ki-67 greater than 20%. So pace of growth matters also. So I may meet a patient who has had stable disease for many years, or I may meet a patient who has rapidly progressive metastatic disease, and that matters in terms of how I select therapy. Primary site matters. As I'd mentioned, some of our FDA approvals are really dependent on primary sites. So for one example, sunitinib is only approved for pancreatic nets, not for other primary sites. And then lastly, of these characteristics, somatostatin receptor is our newest characteristic that matters. This is just a really nice example of the same patient who had an Octria scan. So that's our older imaging tool. It required patients coming back to the facility 2 days in a row. And then our newer gallium-68 dotatate PET that has much higher resolution. I'll just highlight a couple of interesting points. So the pituitary gland is normally a little bit positive on this, as are the liver has some normal background, but then spleen, and then it's concentrated in the bladder. So just a brief overview of what we have in terms of tools for hormone control. So somatostatin analogs are the mainstay of how we treat functional nets, primarily carcinoid syndrome. There are 2 approved agents in the United States, octreotide and lanreotide. These are both approved for hormone control. They have the same affinity for somatostatin receptors 2 and 5. The main difference is that octreotide comes in both a short and a long-acting form. It is an intramuscular injection, whereas lanreotide only has a long-acting form and it's a deep sub-Q injection. Pasreotide is a 3rd form. It's approved in the US and Europe for Cushing's. And then on the right is actually a new agent that was approved a few years ago on the basis of improving diarrhea for patients with carcinoid syndrome diarrhea. Telotrestat blocks TPH. It's the rate-limiting enzyme in the conversion of tryptophan to serotonin. So I participated in this clinical trial when I was at Stanford, and it reduces on average bowel movements about 2 per day. You may not think that is clinically important, but it often helps get patients out of the house. So it's, again, and it's oral, so that's great for patients. There are a number of tools for tumor control. They fall into 4 categories: somatostatin analogs, biologics, cytotoxic chemotherapy, and PRRT, which is peptide receptor radionuclide therapy. I am going to focus today just talking about 2 of these. So we're going to talk about temozolomide and capecitabine on the basis of a large randomized trial that I led through the NCTN, and also lutetium dotatate, which is our sort of first and only so far peptide receptor radiotherapy for this disease. So this was a study, and I think if there are any trainees on, that I started getting involved with ECOG and the National Clinical Trial Network as a fellow and junior faculty. It was a great opportunity for networking and mentorship. Through that, I helped to develop this randomized study for patients with progressive metastatic pancreatic NETs, grade 1 and 2. Half received temozolomide alone and half received capecitabine and temozolomide together. The maximum duration was 13 cycles, so about 1 year. And the primary endpoint was progression-free survival. So this study indicated a benefit of the combination arm with a median progression-free survival of 22.7 months versus 14.4 months with a hazard ratio of 0.58. And the overall survival also showed a statistically significant difference. The median in the temozolomide alone arm was 38 months, and it was not reached in the combination arm. And then in terms of response rate, this is actually a combination that yields one of the highest response rates of any available agent. So the response rate for the combination arm was 33%, and the single agent arm 27.8%. These were not powered to determine a difference between the arms, but I think another important takeaway is that both agents yield approximately a 30% shrinkage rate. So moving on to talk about somatostatin receptors, also just a brief history. Somatostatin was sequenced in 1963. It's a naturally occurring peptide, but has a very short half-life. So analogs were later developed in order to be clinically practical. There are 2 Nobel Prizes on this list. The first is in the 1970s for doctors Gilliman and Shalley on the discovery of somatostatin. And then later in 2012, doctors Kubilka and Lefkowitz were awarded the Nobel Prize for their discovery of G protein coupled receptors, to which somatostatin receptors belong. So I'd like to introduce you next to the concept of theranostics, and this is really important as we think about developing our Yale neuroendocrine tumor program. So imagine you have a group of patients. You'd like to determine whether they have a specific target. You have a diagnostic imaging tool that actually helps select who in fact has that target. And then you have a targeted therapy that goes to that target. So theranostics is using the same target for both therapy and diagnostics. I like to think of this using a lock and key analogy. So the lock is that target, or the somatostatin receptor in the case of NETs. The key is the peptide, or octreotide in our case, and the reporting unit is the payload, or the radioisotope. So the diagnostics for NETs, I've walked you through this a little bit, but it actually dates back to the 1980s in using I-123 labeled octreotide, but then it's been through this entire evolution of indium-111, which is indium-111 octreotide. And so that's the Octreoscan that was approved in 1994. And then in the 2000s, we've had gallium-68 dotatate PET, gallium-68 dotatate PET, and copper-64 dotatate PET. So that, and there's, I put the reference in here, there's a great article that's on appropriate use criteria for these somatostatin receptor imaging modalities. Therapies, similarly, we can think about the lock and key. I use this analogy quite a bit when I talk to patients. So for peptide receptor radionuclide therapy, there has also been an evolution, first using indium-111, in the 2000s using yttrium-90, and then later in the 2000s, evaluation of lutetium-177 dotatate. It was this clinical trial that I had the opportunity to lead while I was at Stanford. And this was an international multi-center randomized trial. It randomized patients with mid-gut or small intestine neuroendocrine tumors 2-to-1 to receive 4 administrations IV of this, this radioisotope, lutetium dotatate, at 200 millicurie versus high-dose octreotide. This was a positive study. So the primary endpoint was progression-free survival. It showed a hazard ratio of 0.21. And this is one of our, and the median PFS was not reached at the time of the study, but is approximately 2.5 years. The overall survival had not been reached at the time of this initial publication. It since has been reported actually just at ASCO this year. It did not officially meet statistical significance, but was a clinical difference of 1 year. So on the basis of this study, this was FDA approved in January of 2018. It was really fun to be part of a process of kind of a novel class getting FDA approved and then the clinical implementation of that. I'd also like to sort of postulate that somatostatin receptors are a perfect target. I'll just mention 4 other agents that are in very early phase studies, but lutetium satyriatide is a somatostatin receptor antagonist. So that ludotatide is actually an agonist. This was an early phase study that actually had quite a bit of grade 4 hematologic toxicity. That led to some dose reductions, and they are pursuing that in later phase studies. PEN-221 is a peptide drug conjugate with DM1 that also just recently completed a small phase 2 trial and did not have a modest benefit rate, no PRs, but had an 88% stable disease rate. Tidutamab is a somatostatin receptor 2 CD3 bispecific antibody, also just completed a phase 1 study. Modest response rates, but had a 55% stable disease rate. Of note, I'll just mention, I didn't go into detail in this today, but single agent checkpoint inhibitors do not work in low-grade neuroendocrine tumors. So the idea of trying to use combination approaches is very attractive. And then lead-212 dotamtate is an alpha emitter, PRRT. Alpha emitters are felt to be have fewer side effects and have more tumor cell killing. This just completed a phase, or in the middle of a phase 1 trial, they just reported some early results. So in their first 10 patients, there was a response rate of 80%. So we are all very excited about the idea of alpha emitters. And so stay tuned on that. And then I did a tutorial kind of on this somatostatin receptors as part of a Twitter tumor board. So what do we know about NETs as we start thinking about translational research questions? Well, we know they're a chronic cancer. We know somatostatin receptors are a unique target. Somatic mutations are rare. Tumor mutation burden is low, and germline mutations are more common than was once appreciated, and existing biomarkers are imperfect. And we have a number of treatments that yield stability. Ludotatide slows progression and shrinks tumors, and the optimal sequence of therapies is unknown. And most patients receive therapies and thus experience years of toxicity. So how can we optimize PRRT? How can we take better advantage of the somatostatin receptor? Can we identify resistance mechanisms and overcome them? And how can we develop predictive and prognostic biomarkers? So the bar is low and the field needs your help. So this is part of my plea to the cancer center community to help me start thinking about translational questions as we develop teams for research. So one such team that I'm part of is the National Cancer Institute Neuroendocrine Tumor Task Force that I chair. I had the opportunity to lead a clinical trial planning meeting this past year, with the objective was to really think about treatment in the era of PRRT. I'll bring you down to the bottom here. Our deliverables are a manuscript that is in process, but really the deliverables are clinical trials. And so we now, out of this like many month process, have a PRRT retreatment clinical trial started, or in development, I should say. And then we have working groups on looking at PRRT plus DNA damage repair, PRRT plus IO, PRRT and liver-directed therapy, and some dosimetry studies. So why build a NET program at Yale? I hope I've shown you that there is a real renaissance in NET research in terms of increased publications and clinical trials. The volume of NET patients at YCC is increasing. There's significant downstream revenue of patients who have a high prevalent disease and are in our healthcare systems for a long time. We have the multidisciplinary expertise from MedOnc and SurgOnc and endocrine and IR and NucMed. Our clinical trial portfolio is growing. There is philanthropic interest. I'd like to specifically thank the Alan and Cheryl Lipson Fund for a generous multi-year gift that we have recently received. And really the timing is right. I think that with my arrival to Yale and really a convergence of all of this expertise, it's very exciting. And we have identified NETs as one of our 4 key programs in the Center for GI Cancers. So I have just a few minutes remaining. I'm going to kind of try to breeze through this, but our Yale NET program is co-led by myself, Darko Pukar, and we are adding Dr. Miriam Aboyan. We have currently a monthly NET support group, and I'm sort of the anchor medical oncologist. We are planning a PRRT clinic, some efforts around nutrition education, and a new theranostics program that Dr. Aboyan will be leading that will really have benefits beyond neuroendocrine to include neuro and GU. As I'd mentioned, we have clinical trials. We just opened our first one, and actually our first patient is enrolling on the NETTER-2 clinical trial this week. We have a biorepository enriched with NET cases, and we have a number of translational team grants, one of which we just submitted last week on looking at sex differences in neuroendocrine tumors. This is the NETTER-2 clinical trial. It's a randomized phase 3 trial for patients with advanced, well-differentiated GI neuroendocrine tumors that are slightly higher grade than the NETTER-1, and it's randomized ludotatide versus octreotide. I have a whole list of my wish list of other clinical trials. These are all NCTN trials that are in queue to hopefully open in the next year. This is a new alpha emitter, as I'd mentioned, where there's a lot of excitement about this, and I serve on the steering committee for this study. So a shout out to the GI tumor biorepository led by Dr. John Kunstman. It's been established for almost a decade, and I'd like to highlight that it's really enriched for NET cases. So we have 106 NET tissue samples, 70 of which are fresh frozen, and you can see the breakdown of diseases, and they're all associated with plasma. So a great opportunity for collaboration. And then lastly, in terms of education, we launched our patient education initiative in November. We have a CME series planned and a number of trainees already involved. Caroline Gordon's a PGY2 who's helping to do a review paper on sex differences in neuroendocrine neoplasms. Tejal Srikumar is helping with a pathology project, and Janie Zhang just completed a really wonderful JCO oncology practice review. So please join us. We have Thursdays I'd like to highlight. We have a great seminar series on Thursday afternoons from 4:15 to 5. And I think I'll end there. So, we're really excited about building this program. I think our next step is really building on some of the translational research opportunities. So thanks.
Thank you, Pam. Very exciting, particularly these tremendous advances in therapy. Those are very impressive Kaplan-Meier plots. So are there questions while we're waiting? I have one quick one. There's a huge increase since the 1970s. Is that just better diagnosis, or is the incidence actually increasing?
So that's a great question. I think that the diagnostics have clearly improved. I think that we're seeing incidentally discovered GI NETs through colonoscopies, so specifically rectal and colon. But I think that it probably goes beyond that. And so some hypotheses have been, are there environmental risks that we have not yet picked up on? So I think some of it's diagnostics, but some of it's something we don't yet understand.
And you may have said this, but I missed it. Do you sometimes have patients with different primaries and different sites?
That would be really infrequent, but can happen with some of our inherited syndromes. But usually they have a single primary site.
Great. Are there other questions in the chat, or raise your hand? Well, I have another question that we talked about briefly before we started. Has anyone looked for viruses in these tumors? I'm asking because, as we'll hear, the next one, there is a virus involvement.
So Dan, good question, and not to my knowledge. And as I was sharing with you, I think that in this particular field, the bar is pretty low. The clinical science, interestingly, was way ahead of some of the basic understandings of the molecular biology. And in fact, we knew that mTOR inhibitors worked clinically before we knew that there were mTOR pathway mutations, somatic mutations. So I think there are a lot of really great questions we still need to ask in this field.
Well, it's great that we have such a strong program here. Thank you for doing that. Seeing no other questions, we'll move on to our second speaker. So well, there is one question, I'm sorry. It just came in from Jeremy J. Cox. Do you see that?
Yes. What are the dominant features of non-SSTR nets biologically and clinically compared to those that are somatostatin receptor positive? So that's another great question. I would say typically the patients who are non-somatostatin receptor avid have more aggressive disease. They tend to have lost that somatostatin receptor as they dedifferentiate. So it usually are the grade 3 poorly differentiated neuroendocrine tumors. As I mentioned, we can see great evolution over time. So sometimes a patient who may have initially been SSTR positive can lose that.
And another question, are there supportive services unique for this population?
So yes, and actually I'm really eager to work. Tara Sampton and I have talked some about this, but I think particularly for the grade 1 and 2 neuroendocrine tumors defined as a more chronic cancer, the chronicity of their survivorship issues, I think is a really unique aspect that we need to pay more attention to. So hopefully we'll have more dedicated services.
And finally, what about differentiation therapy? Isaac Kim has a question on that point.
Yes. So in fact, one wish list for 2022 is to actually bring together a multidisciplinary group of people to examine neuroendocrine differentiation across specialties. So bringing GU, GI, thoracic folks together to really think about this as a team. Neuroendocrine differentiation can be an end differentiation for many cancer types, and I think we know very little about that.
Okay, terrific. Thank you. If other people have questions, you should contact Pam directly. Our second speaker today, how about I get my little sheet out, is Kelly Olino from Department of Surgery. She's an assistant professor and received her medical training at Johns Hopkins and also residency there, then a fellowship at Memorial Sloan Kettering. She came to Yale from the University of Texas Medical Branch. And while in Texas, she was recognized as a Texas Rising Star, a Lone Star, a Provost Scholar, and the recipient of the Society for Surgical Oncology Clinical Investigation Award. Interested in tumor immunology, including melanoma, and her clinical specialties include treatment of patients with melanoma, Merkel cell cancer, which we'll hear about today, and other cancers, and also interested in developing clinical trials, including immune therapy for these diseases. And like what we just heard about, Merkel's is a neuroendocrine tumor with a virus association, which makes it interesting to me. So I'm very interested in hearing what Kelly has to say. Okay, it looks good.
Great, thank you. So again, another neuroendocrine tumor, and again, another instance where it really was here at Yale, seeing more and more of a disease process and really relying on our skin cancer spore and multidisciplinary network to actually build a relatively new program for a rare disease. So I have no disclosures. So today we'll talk about an update on the incidence, the management, and the treatment of Merkel cell carcinoma. And then we'll go into specifically some more recent work that we've done looking at our vast experience and benchmarking that against national guidelines. And then briefly, I'll mention some of the new research, again, supported through the SPORE and through the great relationships that we have through our skin cancer program. So Merkel cell was first described as a trabecular carcinoma of the skin, and it wasn't until 1978 that it was first coined to even be a neuroendocrine tumor. However, at that time thought to be derived from Merkel cells, which is actually not the case. It wasn't until 2008 that there was the discovery of a Merkel cell polyoma virus, which is fairly endemic, as even being a causative factor in addition to UV radiation for this disease. And to be quite honest, we still don't even know what the cell of origin is. There's been some hypotheses that this may be from a pre-pro B cell, which would fit somewhat with the increased incidence in patients with lymphoma. Other work is focused on dermal stem cells as well as dermofibroblasts, but it's still a work in progress. As opposed to melanoma, where we speak about the ABCs, we use our vowels for Merkel cell, so it's the AEIOUs. And these are known to be asymptomatic. They're not painful. The big thing with these and how they behave differently is their rate of growth. when we look at Merkel cell, and the ones that I'm showing you here, one is an in-transit picture on the right, but the other ones, which are seen, we measure Merkel cells in centimeters versus melanoma, we really measure that in millimeters or fractions of millimeters. So this expanding rapidly of a non-pigmented mass really should open the thought that this could be a Merkel cell. It's more likely to be found in patients with immunosuppression, older patients, and again, can be associated with UV exposure. And if one looks, about 90% of each patient will have more than or equal to 3 of these characteristics. The immunohistological diagnosis is always based upon the primary skin lesion. And generally speaking, most patients will present about 50% of the time with localized disease, 35% with nodal disease, and about 15% of patients at the time of presentation with metastatic disease, and up to 15% can present with an unknown primary. So as far as management for localized or Merkel cell carcinoma, it really is a surgical disease. So we recommend that we do a wide local excision with 1 to 2 centimeter margins. When possible, you should perform a sentinel node biopsy, again with the caveat being the demographic population who can be high risk and elderly and may not be the best candidates for general anesthesia. Again, adjuvant radiation, which is very different than melanoma. Merkel cells are exquisitely sensitive to radiotherapy and again are much larger. The only times when we really don't consider radiation, again, for a given patient would be very small tumors, less than a centimeter, no lymphovascular invasion in the setting of a widely margin negative resection. There are times too that if a primary is unable to be resected, for example, a very poor surgical candidate, you could have just local palliative radiation. Similar to melanoma, sentinel nodes are important prognostic value. Now, in the case of a clinically positive lymph node, so a patient presents with a lymph node that you can feel, in that case, the recommendation is that we still perform a therapeutic lymph node dissection, and it's controversial whether or not adjuvant radiation therapy is needed in that context. If someone undergoes a sentinel lymph node procedure, if it's positive, again, the options are to undergo further surgical treatment or to actually undergo radiotherapy. Again, there's lots of series that are all retrospective in nature. We have no prospective data looking at this. Again, even if you're a sentinel node negative patient, again, fairly controversial, radiotherapy, we typically would use here at Yale. There are some centers that still will use that. And that really is for instances, particularly in head and neck cancers, where if you thought that your nodal mapping was poor or inaccurate, that you could offer that to a patient. Adjuvant therapy currently for Merkel cell is just under investigation in actively ongoing clinical trials, including the STAMP trial, which we have open at Yale. So for metastatic Merkel cell carcinoma, it used to be chemotherapy first line with etoposide and platinum agents. Those had very short-lived responses, lots of toxicity, so were abandoned, beginning with 2 clinical trials that were completed and published both initially in 2016 and then updated in 2019 and 2020, looking at pembrolizumab as frontline for metastatic disease with 50% overall response rates, which is fantastic compared to what we saw historically with chemotherapy. And then with PD-L1 agents, adalimumab with 33%, just looking at the overall response rates. And this again continues to grow and expand with additional clinical trials focused on immune therapy. So Merkel cell carcinoma is very interesting because of the end product of your disease looks exactly the same. However, there are 2 completely distinct pathophysiologies underlying the tumor genesis. Interestingly as well, depending on where you live, for example, the US and Europe, about 20% of Merkel cell carcinomas are what we think to be UV related, very different than Australia. In the United States and Europe, again, we see much more prevalent Merkel cell polyomavirus related disease. And what's interesting again about this polyoma virus, it's really endemic. If one looks from China to South America, if one were to swab patients, usually this polyoma virus is found during childhood. 60 to 80% of people will be colonized. If you take out a squamous cell or a basal cell cancer, and if you look for Merkel cell polyoma virus, you'll see that in up to 25% of those samples, even though it's not related to that physiology, at least that we think. And again, any infection with a polyoma virus is really asymptomatic. When we have patients come in, they're very, very concerned that they're going to give this to their spouse or their partner. But again, this is not something that that's really of concern as far as being contagious. And again, the UV mediated Merkel cell, again, we don't know what the cell of origin is. However, what we know is that there's early mutations, particularly in RB1, and those become founder mutations in P53 and RB1. And when we look at the metastases later in patients on autopsy study, you'll see that those are really clonal in nature. However, for virally mediated polyoma virus associated Merkel cell, what you see is actually a critical event where there's viral integration and there's a small and a large T cell antigen in Merkel cell. And what happens is that actually gets incorporated actually very close to where the RB1 gene is. And what happens is that long T cell antigen, as you look downstream, that becomes truncated and becomes a trophic factor and actually drives further growth of the tumor. Now, the things that are interesting in the UV-associated Merkel cell carcinoma, this is very high in neoantigen burden, as well as a high overall tumor mutational burden compared to that of the viral one. However, that has a viral T cell antigen expression. And interestingly, the responses to immune therapy are exactly the same, regardless of the etiology. Why is this important? Such a rare cancer is that it's actually growing. And, similar to the question that was just asked of Dr. Kunz, we were actually really curious as to why we were seeing this. So this is a multidisciplinary effort really headed by Dan Jacobs, who is now a first-year head and neck surgical resident. And this was done with myself, our medical oncology group, Ben Judson from otolaryngology, and Dr. Zhang from the School of Public Health, really trying to answer the question. So how we underwent this analysis is doing something called a age period cohort analysis. Again, similar to what's happening with neuroendocrine tumors and a lot of other cancers, even thyroid cancer. When we're seeing increasing incidence, you want to say, is this related to aging of the population, which is really important for Merkel cell? Or is it related to the calendar period of diagnosis? And the calendar period effect really is looking at, well, are we better at detecting this? Are we more aware of the diagnosis? And so that will equally affect people across all ages. And then the last thing is really, really important is the birth cohort. And that really says, are there real changes in risk factors? Is there something actually changing in the environment that's explaining the increase in incidence that we're seeing in Merkel cell? And we thought that this was a really important analysis to be done, even though this is a rare disease. So what we were able to do is we looked and used SEER data, and we're able to get over 3,700 patients. Again, we saw what one would expect. Again, this is usually a male-dominated disease, almost exclusively found in Caucasians. The SEER registry data becomes a little tricky because it just turns out by chance that the areas that are actually involved in the SEER registry happen to be some of the higher volume tertiary referral centers for Merkel cell in the country. So, that data was a little difficult to interpret. But again, we saw, head and neck primarily, again, just what we would expect to see, localized and regional disease. But the APC analysis itself, what you can see here in panel A is what you would expect. So if we look at by the calendar period of diagnosis, right? So the time that we've diagnosed, and we look at age, older patients, particularly with improving diagnostics, we're seeing more age-adjusted incidence rates happening. And we see that in men and women. More interestingly, if you look at panels C and D, when we look at the birth cohort effect now, compared by age and looking at the age-adjusted incidence, you're still seeing actually an important association due to the birth cohort, which really points to that despite that we're better and more aware of diagnosing Merkel cell, and that we know that this is a disease that's more prevalent in the aging population, there does appear to be something that has changed over time that's an environmental risk factor, although we don't know what that is. So, and again, this is just part of the conclusions of that paper, once again, just saying that the effect of how good we are at diagnosing this is really leveling out, yet the incidence is still going up, and that's not just explained by the aging of the population. So the second thing that I wanted to show again is some original work, again put together by our multidisciplinary team here at Yale, looking at our near 20-year experience taking care of this disease. And once again, this is work put together, the registry really brought together by Andrew Esposito, who's one of our general surgery residents, as well as Dan Jacobs, who had worked on the other APC cohort analysis paper. And they really built this up. And then with the support of our Yale SPORE program, is also now the registry being maintained by Ray Bauman, who is wonderful and really helps us with even our melanoma program. So again, when we look at just our 20-year Yale experience, what we see are similar clinical pathologic features to what one would find at other centers. When we look at the cause of death, what we see is only about 36% of our patients that we see are actually dying from Merkel cell. We see them recurring at rates that are similar to other centers. We do have a little bit more of an enriched in transit population, which may be due to how things are referred to us. Albeit even when we see patients who've presented with de novo disease, I do see more in transit disease than what I would expect if one were to compare that to melanoma. And I think that Merkel cell does have very different biologic behavior. Again, when we look at our final pathologic stage, again, we're seeing similar presentation as to what we would be seeing around the country at high volume centers. So the trends in treatment, again, with newer approvals, there's been very, very quick adoption of increasing frequency of immunotherapy for systemic therapy for patients who are eligible, with a concomitant decrease in chemotherapy. The radiation therapy, again, some of this I think is that we're having more patients who have better systemic treatment options. And some of the earlier patients who are seeing, because I think of improved recognition amongst the dermatologic community in the state. So I think that that explains a little bit of this decrease in the radiation receipt. But again, if we look at our initial nodal management, we're right on par with where we would expect our group to be. And our management is following, yet again, national trends. When one looks at surgical resection rates, the rates in which you're appropriately staging patients' nodal basins, and those patients who are receiving non-surgical management. Again, what we're seeing here, and this is the data that we had pulled from SEER, is we're very much on target with where we would expect our program to be, and in align with what's going on across the nation in high volume centers. But one thing that started to bother me, the more that I learned about Merkel cell, we thought it was a great opportunity when we were looking at our institutional series, was there's many papers that were being published as retrospective series, and they were really solely using overall survival as their outcome measure for trying to make conclusions. And we said, this doesn't really sound right. We think there's competing causes of mortality. We had done our APC cohort analysis. We know that age was driving a lot of this. So we said, which, no one had looked just for this specific disease before, is we said, does this make any sense? Should people be writing retrospective papers using things like the NCDB, which doesn't have disease-specific survival in it, and writing, how we should be managing a rare cancer? And the answer, as you can see here nicely illustrated, is we really shouldn't. So if one looks at by age, if we break this down, patients who are 64, which is young for Merkel cell, up until about 2 years or so, right? Those patients, and even up to 3 years, those patients are actually dying from their Merkel cell. When we get to the more extremes of care, right? Your patients beginning at age 65 to 74, but particularly those above 75, many of those patients, and again, we're talking about patients who are immunosuppressed, they're actually not dying from Merkel cell. So it just makes us pause and say, you know, we just need to be very, very careful, particularly on these retrospective data, how we're looking at it. So again, because we had our own cohort where we could look at recurrence, disease specific survival and overall survival, we said, well, let's take a look at that in our own cohort. And what things that we saw that were associated with overall survival, again, what you would expect, age, female sex was protective. If you were immunocompromised, again, you know, it makes sense that your mortality would be affected by that. More advanced disease if you had in-transit disease. But usually if it's really related to the disease, one of the things that your overall and then your disease specific survival really should, sorry guys, should really actually match up. And here, the disease specific survival and those factors for overall survival are actually quite discordant. The things when we look at disease specific survival, the thing that stood out the most was actually patients who were active smokers with the hazard ratio up to 14, which actually hadn't been previously described, but subsequently there's been 1 or 2 papers which have also echoed this finding. But really some discrepancy, and again, our institutional cohort is limited because we don't have thousands of patients, we only have hundreds. But again, it really made us almost add an editorial to the paper itself, which then was published in the Annals of Surgical Oncology. So the overall conclusions are the surgical and the medical management continue to evolve with the utilization, particularly of immune therapy. For our paper, what we found was that there was little consistency between factors associated with overall and disease-specific survival for Merkel cell carcinoma patients. And as I mentioned, competing risks for mortality, particularly in these older or immunosuppressed Merkel cell patients, makes the use of overall survival a poor surrogate for therapeutic outcomes, particularly in these retrospective analyses. And there are hundreds of papers that I think that this statement applies to. So moving forward, I think that as a community, it will, for these rare diseases, we really need to get more work together for more prospective data. And then just finally, and then I'll pause for questions, I just wanted to just briefly highlight just one segue into some of the translational research, again, that's been aided with the skin cancer spore. So again, we talk about a similar disease with 2 separate etiologies, almost similar to some of what we see now with HPV related tumors. You can have squamous cell tumors of the head and neck. Some are virally associated, some are non-virally associated in UV. So a lot of work that's been done in other fields, and now seeing that there's response to immune therapy really allows you to look at things scientifically in a very, very interesting way, where you can see viral associated, non-viral associated, and see what are the resistance patterns that can develop in both. And we had looked at this again, again, immune therapy being used. But again, when we're looking at resistance, there's work that's been headed by Jeff Ishizuka and Jessica Way, and now Alex Fry, who's a surgical resident in Jeff's lab, is really looking at novel ways that we can take fresh tissue, again, building upon our strengths in our melanoma program with the spore, and really looking at these different conditions and then getting really great data, even on limited samples. And this is work that Jeff has been doing with myself and others, and really pushing forward. Again, all of our data is too preliminary to kind of show in a setting like this, but I'd like to say that maybe a year or 2 from now, that we may have new targets or new ways that we could look at things ex vivo to make better targeted treatments for these patients. So again, thank you everyone for your time, and I'll pause for questions.
Well, thank you, Kelly. Very interesting. I'll start with a question while people are gathering their own questions. Is there any prospect for a vaccine against Merkel cell virus? I know it's a relatively rare disease, which is going to make that difficult, but with new technology, maybe not so crazy.
So it's a great question. So for the polyomavirus itself, it doesn't make sense to make a virus, but it sounds like you've been listening into Jeff and I's research meetings. With some of the new technologies that we've seen with COVID vaccination and so forth, there may be a role for development because there are T-cell antigens with this, similar to something like HPV, where there may be ways that you can do combination of a vaccination approach, almost similar to what Akiko Iwasaka was doing with the cervical cancer. So I think that would be a great field. And if there's any experts that want to work with Jeff and I, just give me an email.
Okay, great. So there are some questions in the chat. Can you read them, or do you want me to read them?
Insights into the differences in biology in the younger patients. So the patients, I worry about patients, particularly who are less than 60 years old. And if those patients who are less than 40 years old, you almost want to double check that you have the right diagnosis. So as you're seeing from part of that analysis that we looked at between mortality and overall survival, again, anecdotally, I think that the disease is more aggressive. I think we may see more metastatic disease. You'd have to look at that specifically, but there's something that's driving that in a different way to have that earlier. And again, these younger patients that we're seeing them in, interesting, they're not immunocompromised.
Jess Sklar has a question. Is there a specific tissue or reservoir for the virus among many people who have it?
It's just on the skin.
Skin.
There's some thought there may be some reservoir also in the GI tract, but usually it's a commensal skin flora.
Brenda Emus asked, over time, is there a difference in the proportion of cases that are UV versus virus associated?
So from our own cohort, unfortunately, we're not able to answer that question. We're creating hopefully a TMA. We're trying to get that together because there wasn't a difference in how patients were treated. Historically at Yale, the immunohistochemistry stain for the polyomavirus in Merkel cells wasn't done, but we're very close to having all of that put together to start looking at that clinically. And like I said, retrospectively, we're hoping to be able to look at that.
And are HIV patients at increased risk of this tumor?
Not if they're well controlled. So more our CML patients. I worry about those. And then probably just general immunosenescence is probably important. Post-transplant, we don't see, they're higher risk for Merkel, but again, it's a rarer tumor. So we don't see this as much as we see horrible, poorly differentiated cutaneous squamous cells. That's usually what we're worrying and battling more with these patients, but we do see it more often in the transplant patients.
Perfect. Are there other questions? If not, thank you very much. A very interesting talk, actually, to both speakers, and we've learned a lot about neuroendocrine tumors today. Thank you.